So our second speaker is Dr. Alessandro Amodeo, who is a resident in the School of Endocrinology and Metabolic Diseases of University of Milan. He currently works in the Unit for Gynecological and Andrological Endocrinology of IRCCS Oxologico in Milan, directed by Professor Marco Bonomi. As a member of Professor Bonomi's team, Dr. Amodeo's main clinical and scientific interest is in andrology and reproductive endocrinology. Alessandro, the floor is yours.
Thank you for your introduction, and thanks to the scientific committee for this invitation to talk about a topic that is a controversial subject because genetic causes are usually associated with congenital and not late onset hypogonadism, which is more often associated with acquired and functional causes, as Walter were showing before. I will try to review the presentation of a clinical condition that could be a little bit more complex than that. This slide is just to remind that the clinical presentation varies according to the age of onset. Absent or incomplete puberty is the typical clinical presentation for peri-pubertal age of onset. Conversely, adult onset hypogonadotropic hypogonadism usually present with complete spontaneous pubertal development, but infertility or sexual dysfunction. When we how we define congenital hypogonadotropic hypogonadism, it's a rare and heterogeneous disease caused by deficient production and secretion of or action of gonadotropic releasing hormone. Clinically, it is characterized by a broad spectrum of a phenotype. We have complete forms in which we have a complete absence of puberty, often associated with signs of deficitary mini-puberty, such as cryptorchidism, microorchidism, micropenis. In this case, it is easier for the physician to make a diagnosis, but the prognosis of patients, especially in terms of fertility, is worse. Conversely, we have partial forms of CHH with a mild residual gonadotropic releasing hormone activity and a milder phenotype, milder but more ambiguous phenotype, but a better prognosis in terms of fertility. The genes that are associated with congenital hypogonadotropic hypogonadism may cause also extragonadal defects. When associated with anosmia, we term CHH Kallmann syndrome. It may present solely or associated with developmental anomalies such as dental or renal agenesis, bimanual stenokinesis, which may serve as red flags to help achieve the diagnosis. But let's talk about genetics. Pathogenesis of CHH is complex and poorly understood, but with a strong genetic component. CHH is genetically heterogeneous. We can find both sporadic and familial cases with different inheritance patterns. Oligogenicity has an ever-expanding role in the pathogenesis of CHH, being able to account for several cases of congenital hypogonadotropic hypogonadism. The genes are involved either in the development and migration of gonadotropic releasing hormone neurons, or in gonadotropic releasing hormone secretion or action, such as mutation of gonadotropic releasing hormone receptor. So far, we have identified more than 50 genes associated with congenital hypogonadotropic hypogonadism, even if, and this is an important point to underline, genetic diagnosis, it is not necessary to make diagnosis of congenital hypogonadotropic hypogonadism. But besides this classic prepubertal onset of congenital hypogonadotropic hypogonadism, adult onset idiopathic hypogonadotropic hypogonadism in men with a complete and spontaneous pubertal development and exclusion of causes of acquired hypogonadotropic hypogonadism have been described. And these authors of this famous New England of 1997 were among the first to describe them. They described that the people with adult onset idiopathic hypogonadotropic hypogonadism had a lower testicular volume and lower testosterone and inhibin B concentration compared to general population, to normal men, but higher compared to classic prepubertal gonadotropic releasing hormone deficiency. They concluded that the normal pubertal development and the documented fertility in some cases strongly suggested that this condition is an acquired condition, but a delayed onset of a genetic defect of gonadotropic releasing hormone activity could not be excluded. But so far, we are apparently faced with two different conditions. Classic isolated hypogonadotropic hypogonadism, a rare congenital disorder with a prepubertal onset and a strong genetic background, and an adult onset idiopathic hypogonadotropic hypogonadism, often considered an acquired disorder, with a gonadotropic releasing hormone deficiency subsequently developed without an identifiable cause. But are they really and always, I should add, two separate entities? This is the question I will try to answer. I show you two studies by the group of Boston. They described in 2008 heterozygous variant of FGF8 gene, which is associated with congenital hypogonadotropic hypogonadism, in a male patient who developed an adult onset hypogonadotropic hypogonadism with a complete and spontaneous pubertal development. The same authors 2 years later described the natural history of 10 men with adult onset idiopathic hypogonadotropic hypogonadism, and they found a personal history of delayed puberty in 3 of them. In one of them, subject 6, they found an heterozygous variant of PROC-R2, a gene associated with CHH, even if a loss of function of this variant was not clearly demonstrated in functional studies. But according to the authors, this history of delayed puberty could suggest a sort of pre-existing underlying gonadotropic releasing hormone defects, which can serve as a sort of genetic contribution to the etiology of an adult onset hypogonadotropic hypogonadism years later. This more recent work by Professor Bonomi, in whose group I have the honor of working in Milan, the author described the nationwide cohort of patients with isolated hypogonadotropic hypogonadism, either prepubertal onset or adult onset, and they found that there was a familial recurrence in both cases, suggesting a common inheritable predisposition, genetic predisposition between these two conditions. Looking at body mass index, they found that obesity is more frequent in adult onset hypogonadism, and this could suggest that in adult onset hypogonadism, the genetic defect could be sometimes milder, and an environmental acquired cofactor is needed, such as obesity, is needed to develop hypogonadism. This from this hypothesis that the same authors described a common genetic origin of classic and milder adult onset isolated hypogonadotropic hypogonadism, studying 160 male patients, studying the prevalence of rare variants by means of next generation sequencing genetic analysis in 28 genes associated with congenital hypogonadotropic hypogonadism. And they found that the prevalence of rare variants in these genes was higher both in prepubertal and in adult onset hypogonadotropic hypogonadism compared to controls, without any significant difference between a prepubertal onset and adult onset. But what I want to underline is how were these genes distributed among adult onset and prepubertal onset. From my point of view, it is not surprising that pathogenic variants of ANOS1, FGFR1, which are strongly associated with stronger and more complete forms of congenital hypogonadotropic hypogonadism, were found only in prepubertal onset hypogonadism and not in adult onset. Conversely, in adult onset, we found high prevalence of oligogenic defects. In particular, the enrichment in rare variants was higher when testosterone levels were below 6 nanomoliter and the age of onset before 31 years. But in reality, is often more complex than that. This is a case presentation of a male patient, 37 years old, who presented with primary infertility. No family or personal history of delayed puberty, apparently, anosmia or cryptorchidism, but a long history of hypospermia and low libido. This patient was referred to us as an adult onset, a suspect of adult onset hypogonadism, but actually at a closer look at physical examination, we found that testicular volumes were lower than normal and a pubic hair development stage 4. Indeed, blood tests found severe hypogonadotropic hypogonadism with otherwise normal pituitary action. At the brief smell identification test, the patient was found to be hyposmic. Pituitary MRI found at an hypophysis of approximately 4 milliliter in height. Olfactory bulbs were not evaluated, and scrotal ultrasound confirmed the testicular hypotrophia. Based on this very low testosterone level and the presence of red flags, I didn't show you that we detected for the first time in this patient bimanual sunkinesis, which I mentioned before as red flags for congenital hypogonadotropic hypogonadism. So in light of that, we performed a next generation sequencing genetic analysis. But why is the NGS so useful? Because different genes can produce the same phenotype. Each gene can produce different phenotypes due to an incomplete penetrance and variable expressivity of each feature, and because oligogenic transmission is possible. But NGS genetic analysis is not always helpful because of the famous variant of uncertain significance, which should be interpreted by means of, in light of clinical data, for example, familiarity, how the variants co-segregate with disease in a multiple affected family member. This is an important information, and information about protein structure and function. And that's important because variants of uncertain significance are found also in general population without causing any disease. And it's for this purpose, and based on the criteria I was telling before, that the American College of Medical Genetics and Genomics published these guidelines for the interpretation of sequence variants to classify variants into a class of risk. This interpretation should be performed at the reference sentence, obviously. So our patient was found to have an heterozygous variant of POLR3B, a gene associated with congenital hypogonadotrophic hypogonadism, but even after the application of the criteria of the American College, this variant remained of uncertain significance as far as we currently know. Anyway, patient started a combined FSH and HCG treatment. He achieved spermatogenesis and spontaneous pregnancy. In conclusion, isolated hypogonadotropic hypogonadism is characterized by a broad clinical spectrum, of which classic prepubertal onset isolated hypogonadotropic hypogonadism and adult onset may represent two extremities. And adult onset, in adult onset, some cases of adult onset idiopathic hypogonadotropic hypogonadism, the genetic defect could be mild, and it works with environmental acquired cofactors such as obesity to develop hypogonadism. So genetics is a sort of predisposition who works in concert with acquired factors. Oligogenicity can underline several isolated hypogonadotropic hypogonadism cases and partially explain its variable penetrance and expressivity. Genetic analysis is useful for genetic diagnosis and family screening, even though it is not always conclusive. And genetic analysis should be considered for patients who receive a verified diagnosis of idiopathic hypogonadotropic hypogonadism with a classic prepubertal onset, obviously, but also for those patients presenting with an adult onset isolated hypogonadotropic hypogonadism before the age of 41 with a very low testosterone levels and or red flags irrespective of the presence of obesity and familiarity. Thank you for your attention.
Thank you, Alessandro. Back to Cristina to announce the next speaker.